This video is a guide to the process of extubation for a confirmed, probable or possible COVID-19 positive patient from the ward who is cared for in ADHB operating rooms. It follows the checklists available in the auxiliary documents and should be used in conjunction with the perioperative COVID-19 guideline. Links to the associated documents are in the description below. Staff and patient safety are our priorities. This process is written in a way to lessen exposure to staff and to reduce contamination. The aim is to minimise the potential for exposure to aerosolization. All drugs and equipment that may be required during extubation and the 10-minute stand-down period should be available in the operating room. The red bell should not be pressed during this time. Therefore, a robust plan for patient management should be established. Closed-loop communication and speaking up are emphasised. The extubation brief checklist is available in the auxiliary documents. This brief is led by the anaesthetist and involves the airway team and circulating nurse. This occurs after the patient has been moved back onto their ward bed.
Now that we have him across on his own ward bed and the surgical team are doffing, why don't we go through the extubation briefing? So what we want to do is ensure optimal conditions to minimise the chance of any extra aerosolization. So I've already got the head of the bed up, and before we extubate we'll make sure he's well oxygenated. Now let's talk through some contingency plans. In terms of coughing, let's continue the remifentanil infusion, and we have some lidocaine drawn up. So when the time is right, I'll ask you to give 5 mils of lidocaine.
Sure.
Like this. If he happens to get agitated, then we have propofol drawn up, and we can give 1 or 2 mils of that.
I'm also happy to step in if anything.
Thanks, Olivia, that's great. And there's always a chance that we'll need re-intubation. So propofol and succinylphonium are drawn up. And Chris, we've got the emergency boxes in the room. Okay, so that's on the trolley. We've got the lidocaine and we've got Sugamidex for reversal, and we have the emergency drugs there on the machine. Now, my plan is to recover him myself in theatre, but we should inform PACU that we're about to extubate. Olivia, would you mind calling in to let them know?
Sure, I'll notify them now.
Thank you. Does anyone have any other concerns?
No.
Okay, great. But please do speak up if we've forgotten anything or you have any concerns while we extubate.
Sounds good.
Thanks.
The extubation process is available in the auxiliary documents. This process occurs after the operating room staff have doffed and left the operating room, and only the airway team, and when appropriate the circulating nurse, remain. The reader and circulating nurse, if present, remain 2 metres from the patient and behind the patient's head.
Are we ready to begin the extubation process?
Yes.
I will read each instruction aloud and then pause for the action to be performed. Please confirm verbally when each action is complete. I'll just check that Olivia and I are more than 2 metres from the patient's head.
Yep.
Rubbish bin on the left within easy reach of an anaesthetist.
I'll get that.
Airway tray with face mask, Vidal and syringe on right side of patient.
Thanks, Chris.
Place the surgical and Hudson mask on left of patient and connect Hudson mask to oxygen supply, but do not turn on.
I'll pass it to you.
Thank you. I might have done that earlier.
Okay. Connected but not turned on.
Suction airway if required. Resheath the anchor and place under pillow.
Okay, I would like to suction.
Sure.
Can you turn it on for me, please?
Of course. Suction on to maximum.
There we go. Okay.
turn off anesthetic, reverse paralysis, and plan for smooth emergence.
Okay, so could you please give 2 mils of Sugammadex, 5 mils of lignocaine, and turn the sevoflurane off, and I'll get you to put it on 100% at 10 litres a minute.
Sure. So Sugammadex going in. So connect to the patient. Injecting 2 mils. 2 mils in, doctor. Lignocaine. Attached to the line and injecting 5 mils, wasn't it?
Yes, please.
So 5 mils going in. Ensuring that the drip is running.
Yeah.
Opening the drip, doctor. And running. So the sevoflurane is off.
Great.
So 10 litres and 100% oxygen.
Fantastic.
Confirmed.
Okay, Catherine.
Anaesthetist, remove eye tapes and tie from ET tube.
Okay. Okay, that's freed up.
Tech switch machine to manual ventilation and open APL.
Hold on a second.
Sure.
Yeah, he's just starting to breathe, so you can turn off the ventilator.
So I'm going to switch the bag, doctor, and APL is open.
Thanks.
Please listen to this full statement before starting. When ready, anaesthetist deflate cuff, remove ET tube and place into bin. Face mask to be immediately applied by anaesthetist using two-handed technique while respiration is assessed.
Kevin, take some nice big breaths for me. That's good. Now open your eyes. Take another big breath. Okay, deflating the cuff.
Sure.
Okay. Still breathing nicely. That's good.
Please listen to this full statement before starting. When appropriate, remove face mask and place with filter into dirty tray. Immediately apply surgical mask. Hudson mask to be placed over surgical mask. Tech turn on auxiliary oxygen supply.
Looking good. Put that under the pillow.
Sounds good.
Yeah. And 6 litres of oxygen, please.
6 litres coming up. 6 litres.
Tech end case on ventilator control screen.
Edging case.
Let's do it.
Ending. Now.
Anaesthetist pick up dirty tray and place carefully in the bin. Remove outer gloves, perform hand hygiene, and re-glove if necessary. I will start the 10-minute stand-down timer now. Leave the suction under the pillow. After the patient leaves the room, the suction is turned off and disposed of and tapped with canister.